Okay, so today we are going to talk about stroke. We will talk about different types of stroke, what are the arteries that supplies the brain, and what if those arteries are blocked, what are the parts that get affected, how do you manage a patient of stroke in emergency, what is the acute treatment of stroke, and what is the chronic therapy for stroke patient. First, we will define about the stroke. So what is stroke? Stroke is defined as an interruption or reduction of blood supply to an area of brain that result in the brain death, that is called as the stroke. Stroke has mainly two types, ischemic stroke and hemorrhagic stroke. In ischemic stroke, the arteries that are supplying the brain, that arteries get blocked, that is called as ischemic stroke, that can result in death of brain tissue, and when the arteries is ruptured, that is called as the hemorrhagic stroke. Ischemic stroke is our main focus of this video, but we will briefly talk about hemorrhagic stroke as well. Hemorrhagic stroke has various types. First one is the subarachnoid hemorrhage, when the bleed is around the brain. Second one is the intraparenchymal hemorrhage, when the bleed is within the brain. Ischemic stroke can be two types. First one is the embolic and second one is the thrombotic. So let's talk about embolic stroke. Embolic stroke are the one in which the clots from anywhere in the body, they get stuck in the vessels that are supplying the brain, resulting in blockage of blood supply to the brain and tissue death. So it can be due to the atrial fibrillation or can be due to endocarditis. Both are the conditions in which clot is being formed in the heart, and those clots block the arteries of the brain. Next one is the thrombotic stroke. Thrombotic stroke can be result from chronic atherosclerosis, deposition of fats within the vessels. The deposition of the fat decrease the lumen size of the vessels, resulting in decreased blood supply to the brain. The risk factor of the thrombotic stroke are the same as coronary artery disease. They are hypertension, diabetes mellitus, smoking, and genetics. Now we will talk about blood supply of brain. Blood supply of brain mainly consists of anterior circulation and posterior circulation. Anterior circulation arises from internal carotid artery, and posterior circulation arises from vertebral arteries, that arises from vertebrae. Anterior circulation includes anterior cerebral arteries and middle cerebral arteries. Posterior circulation includes the vertebral arteries, basilar arteries, and posterior cerebral arteries. All of these arteries combine to form circle of Willis. Now we will discuss what if those different vessels are blocked. What are the areas of the body that are get affected by blockage of these vessels? Remember, any stroke in the brain always affect the opposite side of the body. If there is a stroke on left side of the brain, it affects the right side of the body. If there is a stroke on right side of the brain, it affects the left side of the body. If anterior cerebral artery is blocked, that result in stroke that affect legs and feet much more than upper limb. It also affects the upper limb, but the legs and feet are prominently affected in anterior cerebral artery stroke. In middle cerebral artery, it mainly affects face, arm, and speech of the patient. Speech is very important. If the speech of patient is affected, it suspects the middle cerebral artery stroke. If posterior cerebral artery is affected, it mainly affects the eyes. When paramedian arteries are affected, it damages pons, and damage to the pons result in Lockin Syndrome. In Lockin Syndrome, the whole body is paralyzed except a single body part, that is eyes. If vertebral basilar arteries are affected, the main symptom is syncope. Whenever a patient presents to you with focal neurological deficit in your clinic, that focal neurological deficit can be unilateral weakness of the body, paralysis of the body, sudden loss of vision. All these symptoms are focal neurological deficit. The first thing that you have to do is to order non-contrast CT scan. Since taking contrast will take time, non-contrast CT scan will give you a result more rapidly than any other. What we are trying to do in non-contrast field, we are trying to look at blood in CT scan. If there is a blood present in CT scan, it points out toward the diagnosis of hemorrhagic stroke. If there is no blood in CT scan, it is ischemic stroke. So we want to see whether there is a blood in CT scan or there is no blood in CT scan, because both ischemic stroke and hemorrhagic stroke have totally different management. This is a CT scan showing blood in the brain. White area shows the bleed. Blood is white on CT scan, and if you see a blood on CT scan, it is a hemorrhagic stroke. and you have to initiate your protocol for hemorrhagic stroke. The only thing that a physician or intensivist can do in hemorrhagic stroke is they can lower down the blood pressure to decrease bleeding and raise the job of neurosurgery department. Or neurosurgeon will either go for a craniotomy, in which they open up the skull and decrease the pressure in the brain, or they will go for a coiling if they pass a coil in the vessel and they stop the bleed, or they clip a vessel by opening the brain. So that's how you manage a hemorrhagic stroke. What if you see no blood in the CT scan? What if you receive a CT scan like this, in which there is no white area, no blood, instead you see a black area like this. Black area is ischemia in CT scan. Usually you do not see any changes in the CT scan immediately when a patient came to your hospital. These ischemic changes takes hours to develop and the CT scan mostly normal, but the patient is having focal neurological deficit. Now we know that a focal neurological deficit is due to ischemic stroke, and we have to treat the patient according to ischemic stroke protocols. Whenever a patient presents to you with a ischemic stroke with no blood on CT scan, the most important decision that a doctor has to take that whether a patient should be given a TPA or not. TPA is tissue plasminogen activator that breaks up that clot which blocks the blood vessel. But when you are breaking up the clot in the blood vessel and reinitiating the blood flow to the brain, there is a risk that ischemic stroke become hemorrhagic stroke. By breaking that clot, you can convert the ischemic stroke into hemorrhagic stroke. So there is a higher risk that when you are giving a TPA, that ischemic stroke become a hemorrhagic stroke. Usually TPA is given to the stroke patient if they present within the 4.5 hours of the focal neurological deficit or within 3 hours. If the patient presents after 4.5 hours, or if the patient has a contraindication to TPA, you cannot give a TPA to that patient. That patient is now given aspirin. That is emergency treatment that you gave to the patient. Now either the same day or the next day, you will have to do a certain investigation to find out the cause of the stroke and to prevent the recurrence of the stroke. In those investigations, the most important thing is ECG, in which you look for atrial fibrillation or atrial flutter that can cause the embolic stroke. You can go for echo to look for clots, and you can go for carotid ultrasound to look for atherosclerosis in the blood vessels. If you do ECG, you find atrial fibrillation or atrial flutter, you will have to start a patient on anticoagulants. In anticoagulants, you can give warfarin or any other novel oral anticoagulant drug. Usually, whenever you start a patient on warfarin, you need to give a heparin bridge. But in this patient, in atrial fibrillation, you do not give any heparin bridge. If you do echo and you find a clots in heart, you will have to go for anticoagulants. Now coming to an important investigation, carotid ultrasound, in which we are trying to find out atherosclerosis in the blood vessel which are supplying to the brain. If that atherosclerosis is causing less than 70% of stenosis with no any symptoms to the patient, this patient is need to be treated medically with statin drugs to stop the atherosclerosis process. If the patient with the greater than 80% of stenosis or greater than 70% of stenosis with symptoms, that patient needs to be treated with surgery. In surgery, you have options like rotated endarterectomy or stenting. This is the picture showing carotid stenting. If you see this, this is atherosclerotic plaques, and there are the blocking the blood vessels, and the wire is being passed and a balloon is being inflated to open up the blocked blood vessel. This is called as carotid stenting. Now see this picture. This is a picture showing a carotid endarterectomy, in which these are the blood vessels and this yellow part is atherosclerotic plaque that is blocking the blood vessel. Then the blood vessel is open and the atherosclerotic plaque is removed. After removal of this atherosclerotic plaque, that vessel is stitched back to its normal position, and that is called as carotid endarterectomy. So we can go for either carotid stenting or carotid endarterectomy if the stenting is greater than, or if the stenosis is greater than 80% or 70% with symptoms. What are the investigation that you need to do the risk assessment of the patient? You have to check a HbA1c to look for diabetes. You have to go for lipid profile. You have to go for complete blood count, coagulation profile and TSH. Now what are the acute management of stroke? In acute management of stroke, we talk the most important decision that a doctor has to take. It is to give a TPA or not. If the patient has an ischemic stroke and that the patient is diabetic and they are presenting with 3 hours, and that patient is usually given a TPA. If the patient is having ischemic stroke and they are non-diabetic, if they are presenting within 4.5 hours, so according to neurological deficit, that patient is given a TPA. TPA is not given to the patient if they are presenting after this time, or if the TPA is contraindicated as it is in an intracranial hemorrhage or history of bleeding recent surgery or any other recent trauma, because TPA will undo each and every clot in the body, resulting in rebleeding. Heparin is not used in the acute management of stroke. If the patient did not receive a TPA, or if the TPA was contraindicated, or if the patient presented after the 3 hours or 4 hours, then that patient is usually given aspirin 325 mg. Blood pressure control in acute management of ischemic stroke is very important. While in hemorrhagic stroke, we lower down the blood pressure. In ischemic stroke, we do not lower down the blood pressure very rapidly and we let the blood pressure stay high. That is called as permissive hypertension. If the patient is having ischemic stroke and a no TPA was given, usually blood pressure is kept below 220/110. If the patient is given TPA, now you have to lower down the blood pressure less than 180 to less than 105 to decrease the risk of conversion of ischemic stroke to hemorrhagic stroke. We talk that it can occur with TPA, so it is still kept below 180/105, but it is lowered down very rapidly in hemorrhagic stroke. You lower down the blood pressure less than 150 to 80. So in hemorrhagic stroke, you lower down the blood pressure. In ischemic stroke, you let the blood pressure stay a little bit high. That is called as permissive hypertension. Chronic management of the patient with stroke includes heparin. Usually these patients are paralyzed. These patients are highly prone to develop deep vein thrombosis. Prophylactic low dose of low molecular weight heparin can be given in chronic therapy. In antiplatelet therapy, aspirin is given. If the patient has first stroke, low dose of aspirin is given. If the patient condition is still not controlled with aspirin and there is a repeat stroke, the patient is given aspirin with dipyridamole. And if the patient has the aspirin allergy, the patient is shifted to clopidogrel. Just like the coronary artery disease, where we combine the aspirin and clopidogrel, in stroke, aspirin and clopidogrel are not combined. Dual antiplatelet therapy of aspirin and clopidogrel is not recommended. In chronic management, you control the blood pressure, preferably with ACE inhibitors and diuretics. And if the patient is diabetic, you control the blood glucose level, you bring it down to less than 7%. Statin therapy is very important to stop the atherosclerotic process of the blood vessel. To control the lipid profile, you give high potency statin, either 80 or 40 mg depending upon the patient. Anticoagulant is not given in the acute management, but in chronic management, anticoagulant is given. If the patient has an indication, if the patient had atrial fibrillation as we saw on ECG, if the patient has AFib plus stroke, the chart score is 2+, you have to start the patient on warfarin and novel oral anticoagulation drug. In chronic management, the rehabilitation, you have to go for speech therapy, occupational rehabilitation and physical therapy. So it is all about the stroke. If you like our video, please do like, share and stay healthy.